Athletes, take your mark. Get set. It's time for the Addict to Athlete podcast. Everybody out there, Coach Blue Robinson here. Hey, I want to thank you all so much for downloading, sharing, and subscribing to the podcast. We greatly appreciate you doing so. As always, keep an eye on that website, addicttoathlete.org. You'll find all of our backlog podcast information about the team, how to start a chapter of Addict to Athlete in your community, and so much more. We got a lot of events coming up in 2025. Check out our schedule, our calendar. And if you have something you would like Addict to Athlete to be part of, let us know. Reach out through the contact information there on our website. Athlete's got a great guest in studio today. He becomes one of the select few that's had multiple appearances here on the podcast. And as you hear the content we're going to be talking about and discussing today, you'll understand why. We've grown to love Dr. B and all that he does for the individuals in recovery. He specializes in addiction medicine, and the information that I think we're going to provide today may help a lot of you as you navigate what's out there and available for your abilities to hopefully use as a method for your own personal recovery through addiction or mental health. Dr. B, welcome back again to the Addict to Athlete podcast. I always feel so humbled talking to you, brother. I appreciate you being willing to do this. Before we jump into this, for anyone that hasn't heard, would you mind just giving a little bit of an introduction and background on you, why you're specializing in this form of medicine, and then we'll kick off today's subject.
Sure, and I'm actually it's an honor to be back here, and you're always too gracious in describing me, and I thank you for that. A little bit of background: most of my career, I was in academic, what would be described as an academic emergency medicine physician, and I was at the University of California for a long time. So I've seen, I've experienced with, I've seen now at this point, over 100,000 patients, mostly in emergency medicine, acute critical care, acute trauma, so forth. And with that, toxicology, substance abuse, all that stuff. And several years back, I made that transition and started practicing strictly substance abuse, and gave up my professorship. Here I am. And that's what I've been doing. And I have a little channel, a YouTube channel, which we just changed the name, by the way. Let me do a little plug-in for myself. It used to be Dr. B Addiction Recovery, I think. And we're also on Facebook and on TikTok and Instagram. And it's Dr. B 360 now. It's
Brilliant.
We just relaunched it, and that's where we're at.
Brilliant. We'll make sure those are in the show notes. But listeners, if you're familiar with Dr. B, then you know that he provides great content, and subscribe to those channels. But today we want to focus on something that I'm getting a lot of, inquiry about. They've got a lot of folks that are coming through my addiction program, but more specifically with my mental health private practice, and they're looking for some alternate, solutions for trauma therapy, for overcoming some pretty heavy emotional barriers. And something that I've been seeing a lot lately, and there's a lot of these clinics popping up around my area here in Utah, are ketamine treatments, Dr. B. And I'm curious, I don't know much about ketamine other than I remember when I first went through school back in 2000, they were talking about substance use and substance abuse, and we're talking about ketamine, going into the K-hole as a recreational drug, people using, which is a pretty heavy substance to be abusing. And so when it kind of emerged as a possible therapeutic, outlet, I was kind of like, are you sure this is good? This is bad? What is this? So Dr. B, would you mind if we discuss today, ketamine? How does it work? Does it work for mental health and addiction recovery? And then let's jump into some of the nuances of this, because I don't know if this is a fad or if it has legitimate backing, but I think there's no better person to discuss this with than you. Let's jump into today's topic. What do you think, and what can you tell us about it from your perspective?
Sure, I'll do the best I can. And you're absolutely right. There's, as with everything nowadays, there's a lot of information out there, not too much knowledge, and not too much formal thinking and approach to things. I think with ketamine, it suffers the same fate as everything else in our current society. There's uh, uh, it's a byproduct of our whatever you want to call it, but financial structures, capitalism, and
Right.
and so that really muddies the waters and the information. if I may, let me make it there's many ways to approach this, and we don't have much time, but I want to give a little historical background on ketamine. And so,
Yes.
if we kind of couch it in that, we have a framework to think about ketamine. Um, One thing that people don't realize is chemically and structurally, ketamine is the cousin, the first cousin of
Hmm.
PCP, the drug
Right.
PCP. It's exactly that, with some tweaks. And historically, 50s, 60s, I think, PCP, the intention was to be used as a dissociative anesthetic. And I'll
Mm.
talk about a little bit about what that is.
Yeah.
And it's just what it sounds. When you use a dissociative anesthetic, you're going to have some sedation. You are actually also going to have some pain control.
Mm.
You will also disassociate. Okay. And,
Wow.
it's like your body's not there. The problem with PCP, as it turned out, was the emergence reaction was just brutal, right? It was just too
Right.
much. And you would have too many people having this, what's called clinically an emergence reaction in a very, very severe way with agitation. And we've seen people abusing PCP. I think eventually it ended up being used in veterinary medicine,
Yes.
and they came up with ketamine. Okay. And
Mm.
ketamine became, started to be used. Now, that is how it was used. Now, with the counterculture, and at some point, make sure I make a distinction between this associative anesthetic of ketamine and its role in substance abuse. It is a
Right.
Schedule 3 medication because it has somewhat of a good potential for abuse. It really was abused in the late 60s all the way to the mid 70s. If you ever read, and I think there was a movie of Hunter S. Thompson's Fear and Loathing in Las Vegas,
Yes.
when you watch them walking, uh, they're trying to using cinematography describe a K hole, a
Right.
disassociation. They were loaded with everything, but
Hmm.
that's what it is. So it was also a substance of abuse in the 70s, and it's still prevalent in a lot of the counterculture, the raves, and so forth. Okay.
Right.
Now, in clinical and medical setting, it can be used, and emergency doctors do use it, and other doctors do use it. I always only personally used it for children. Why?
Mm.
For me, in adults, there's too much of an emergence reaction. You don't get that. So you get a kid that, and just so you can conceptualize what it does to you subjectively, let's say you get a kid that comes in, he's got a broken bone, right? And I'm
Hmm.
like, you know what? I just got to set that. All right. And it's very painful, and they have to be sedated. Whether I don't want to, I don't have time for IVs, whether I don't want to put a tube down their throat, nor do I want to risk using something and they lose their airway by stopping breathing, and then now I'm in big trouble. Ketamine is perfect. I can do it intramuscularly if the kid's thrashing about, and I'm using this as an example so people get a
Right.
sense of what this stuff is. You use the appropriate dose, minimal danger to the airway, they get sedated. Now they disassociate so they don't feel the pain. And it's important to understand in what it does. It's a central nervous system acting molecule,
Mm.
and it hits NMDA receptors. It's an antagonist, it blocks them.
Mm.
And so those receptors deal with glutamate, which is the primary excitatory receptor in the central nervous system. It's
Right.
not hitting pain receptors. What
Hmm.
is it hitting? The
Yeah.
reason I'm explaining this, I'll come back. It's
Please.
hitting really your perception of pain. Now, this
Oh.
has a big role actually in pain management when we come up in time. If used appropriately in a multimodal way for serious chronic pain patients,
Hmm.
it can really be very efficacious in dealing so they don't have too much opiates. So the dosing of opiates over time doesn't go up. Why? Because what it does is it doesn't let opiates to get, that pathway
Yeah.
doesn't get hypersensitized. There's also the issue of opiate induced hyperalgesia, which is
Right.
connected to your perception of pain. So think about a
Mm.
serious chronic pain patient, how good this could be used. That's
Yeah.
pain. Now, but in conscious sedation, that's how I describe how it's used and why it's been
Mm-hmm.
used. It became into popularity for pain in the 2000s after, oh, we got a opiate that no one can have opiates. So they started using that aspect of it, right,
Gotcha.
for
Yeah.
adults as well. And for pain, there are subtherapeutic dosing. It's slightly less dosing where people can have the disassociation.
Mm.
You just hit enough, now you're at the pain level. That's the general concept. And with that,
Oh.
even comes a lot of problems because everything has to be used in context and with systems working together.
Yeah.
You will get guys that will come in and start trying to abuse this stuff in the ER, right? But the
Mm-hmm.
doses are pretty low. So it's a very, very valuable drug in pain, in conscious sedation. The side effects are obviously this emergence reaction.
Right.
How did it get to the issue of depression? Now, think about it how we suck as medical doctors and our medical establishment in many ways. You think about it, and one of the first ones, and I won't even go into the history of depression and pharmaceuticals for depression, you know, in
Mm-hmm.
the 40s and 30s, they actually coined a nonsense term melancholy as a sort of depression, and they were
Yeah.
giving people stimulants for that. Okay,
Hmm.
well, the thing that really got these guys kind of jumping on the bandwagon to really get to start exploring antidepressants over all that time, which included everything from lithium to, oh my God, it goes on and on.
Yeah.
Was the fact that all of a sudden they saw penicillin is extremely marketable. It
Right.
had mass effects and it was positive. This started the race for looking for pharmaceuticals for psychological issues with depression and really push that. And we come up to the 90s and 80s and 90s. We got this. It's the monoamine oxidase, Prozac, right? It's
Right.
a SSRI, serotonin. Well, one, if they're sitting here meditating on this stuff, they should ask themselves, I thought it was serotonin. Then other ones, norepinephrine.
Yep.
Well, the for the most part, the therapeutic intervention in terms of pharmacological intervention for depression is a failure. Okay,
Yeah.
it
Yeah.
really is a
It is.
failure.
Mm-hmm.
And through those failures, we're also finding out that system is a lot more complex, and it also has to do with the glutamate NMDA pathways.
Mm-hmm.
And so they started messing around with ketamine and blocking that excitatory pathway. And
Wow.
so it started exploring that whole thing. And let's bring it up and skip all the fun details. And you bring it up, and now, eventually, how long has it been? A couple of years, I don't know. But
Right.
you have the
About.
nasal spray of this stuff. What is particular about the nasals? So to your question, the
Mm-hmm.
only thing that is FDA approved is the nasal spray of ketamine in a
Mm-hmm.
psychiatrist's office under a protocol. I don't know what it is, 2 to 3 times a week. They're under
Right.
supervision so they don't
Mm-hmm.
have emergency reactions and so forth. And that nasal spray, whatever it's called, S-ketamine, it is, if you take molecules, any molecule, organic molecules, imagine yourself standing. I think a lot of people may know this. If you
Mm-hmm.
stand in front of a mirror, the opposite of you's on the other side.
Right.
In nature, or when you create a molecule, you create this three-dimensional figure and that one. They're
Right.
not the same if you turn around. One is
Yeah.
called S for sinister because left-handed people are sinister, so I guess I'm sinister. And one is
Yeah.
called R for right-handed people. The one you see in the psychiatrist's office approved at a certain dose, it only the nasal spray is the S enantiomer, they call it, or the S molecule of
Right.
that mirror molecule, not the R. The natural molecule has a bunch of S and a bunch of R,
Yeah.
and now we're actually finding out the R might be more beneficial
Hmm.
for depression. And the way it treats depression doesn't have much to do with the glutamine. It's downstream all of these other molecules that we're finding that have to do with depression, much
Hmm.
more than just serotonin, norepinephrine, or the monoamine group of molecules.
Right.
So that's that. Now, along with this comes the what your patients are. And when you say depression, this is important. It is
Hmm.
only approved for treatment resistant depression, which I think they define, and
Hmm.
suicidal tendencies.
Right.
And when treatment resistant, I think you have to have two different antidepressants of two different classes that you failed on.
Gotcha.
That's it.
Hmm.
Now, when you see these clinics, they're giving the regular molecule. The protocols are different. I don't know. They're
Right.
intravenous and they're very expensive.
Yes.
They might give it for PTSD,
Right.
anxiety, depression, and there's some evidence for alcoholism.
Hmm.
And people go and they, for the most part, it seems that they are reporting, feeling better. But that doesn't mean anything for me, right?
Right.
This is a very complex issue, and we seem to respond to our immediate. I mean, if I'm depressed and I did a line of cocaine, I feel pretty good. Should I
Hmm.
do cocaine every day? I always like to use that analogy.
For sure.
So, what your patients are asking about is that kind of thing. If
Hmm.
it's a very narrow indication and approval, and even in that space, we don't necessarily know everything or long term outcomes. Which, if you're abusing the drug at high doses, one of the side effects is cystitis, which is inflammation of the bladder,
Mm.
cognitive memory decline.
Right. Right. See, and that's some of the questions that I have because everything you said is absolute gold and it makes a lot of sense. And I think listeners, I want you to pay particular attention to what Dr. B just said about treatment, and therapeutic resistance, meaning that you've done things through, working with your physician that have been proven not to work. And so this should not be a right out the gate kind of thing. And the other question I have though, Dr. B, it makes a lot of sense. I thought ketamine was strictly a pain derivative, but it's not. Like you said, it changes the perception of pain, which for any of you out there, like I call you the muggles, the non-magic folk, the ones who haven't abused substances, that's kind of the euphoric part of like you being able to like escape the reality. And so think about it like I love the Fear and Loathing in Las Vegas because all of us have seen that, and it's perfect where they're in the picture, but they're really out in another world. So to be able to microdose this or to, produce this, I am curious because how long do these last? I mean, I think to each person their own, but like the half life of this stuff. Once you, let's say, get to a clinic where you do the nasal, because that's what I've heard is most common here with the clinics that I've noticed. Um, the person taking it has to have someone that's going to be watching them. They have to have someone that's driving them. What I also notice is that you simply going in and taking a dose of this, listeners, is not going to really solve the trauma or the depression. That's just a mechanism for you to open a pathway to perceive maybe the rigid kind of roadblocks that you establish to not let things out or to not, process the stuff with your therapist. This kind of weakens that a little bit, makes you more prone to see other solutions, maybe takes down the defensive wall. Dr. B, I'm curious, is that sustainable after treatment, or is this something that you've heard of that needs to be long-term? Like, how long do these things go? Because I know they're time sensitive, meaning you have you have like 4 or 5 sessions progressively through the weeks, whatever, and then you go through a distance of abstinence without using it. I'm just curious. It's still so new to me that, is this a long-term thing? I mean, it's not a silver bullet by any means. I mean, there's got to be, like you said, a lot more to it than just taking it and then saying, take 2 of these and call me in the morning. Like, that's not the way this specific treatment works, correct?
Yeah. So if we're talking about what it's indicated for, and I'm not sure where your patients are going if they're going to ketamine clinics, which they'll give it for anything through IV, and so
Yeah.
they could give it, I guess, through nose. But if even if they go to a psych, let's take the best case
Mm-hmm.
scenario where you've failed, and now you go to a legitimate medical psychiatrist, and he says, "Yep, we can do this." And you get however long the treatment is, I don't know, a couple of weeks or whatever. And I think your question is this ongoing? Do you keep doing it, and how for? Well, let's
Mm-hmm.
let's remember, if you look up any of the whether it's World Health Organization or substance abuse and mental health in the United States here, um, um, the first line approach. Sorry, I'm getting over a cold.
You're
The
fine.
first line approach for depression is therapy, talk
Right.
therapy, even in those cases. So, so I think it's a good educated guess to think of this, that even, and it's not talked about, but really I think the idea is absolutely to be doing your therapeutic process, whatever that may be, whoever the therapist or counselor is, and continue that in the long run.
Mm-hmm.
And I don't there we don't have data on the efficacy of this in the long run. Okay,
Right.
so I'm going to be hesitant of commenting on that.
Right.
And when these studies come out, you know, uh, it's aimed for the short term and it's aimed to make money. Now that doesn't
Mm.
mean,
Yeah.
and I think what ends up happening as I've seen drugs over years is, look, you're going to spend $3 billion. I'm just saying that, to develop a drug, and this wasn't developed. This was actually pretty easy. It's already there, and they just patented it and so forth. But you come up with that money. Now you want to recoup that money and make a profit. So you try to make as many sick people as possible, or you try to expand the indications for your it's just good business, right?
Right.
There's no conspiracy here. It's just clear as daylight. And our literature, I won't even go into how bad it is. Literature, no longer do you have pure academics. I mean, it's one of the reasons I kind of walked away.
Yeah.
Everything is sponsored, and everything, if you want to make a living, everything is kind of driven by the pharmaceutical industry. So
Mm-hmm.
do I believe there? So I won't comment on the long term. I will suggest be cautious. I will also say that there's something we can learn in this is, and we just don't learn it as a collective.
Mm-hmm.
Is, look, good things take time.
Yes.
Life, meaning, self development, health is a habitual process that's almost boring, but inside of that boring, you will find meaning. I can't,
Yes.
I always tell my patients, I can't offer you a meth rush,
Mm.
but I can offer you meaning.
Yeah.
And having a meaningful existence is
Love it.
worth a lot more than a quick rush. And same
Yes.
here. Having slight depression at times is a normal expression of being
Yep.
human.
Yep.
Go through it, learn from it. Now we're dealing with people with comorbidities, both you and I, substance
Mm-hmm.
abuse and a lot of other crap. I get that.
Yeah. Yeah.
But in general, that attitude in our society is part of the reason we have so much substance abuse, right?
Agreed. Mm-hmm.
So, yeah, don't be in such a rush to jump into it. And we don't have data for long term. And if they, if they did, and if it's negative, God help us getting it published.
Yeah, exactly, exactly. And I think that's part of it too, listeners, is this is something that you've kind of considered. Dr. B, I'm curious, just from your own personal perspective, are there any medical or psychological conditions that could make ketamine unsafe for an individual? I mean, potential for abuse, all those things. I mean, what are some of the things that might make it maybe not the best option for you? So make sure that you really consider alternate solutions before jumping into what you think might be a silver bullet.
Sure. I want to, everything I said before, I just want to add one caveat.
Please go
I
right ahead.
absolutely believe in that there's amazing therapeutic benefit and potential
Yes.
for the molecule of ketamine. I just think in our society, the way we're set up, the way information is translated, transformed, passed on, makes things dangerous. So that's what
Yeah.
I want to say.
Well, that's the thing,
And
right? You're right because we before we hit record, we talked about the situation with the Friends actor Matthew Perry, who we discovered months ago that ketamine was a contributing factor to quite possibly the untimely death, and so people kind of get a little bit of fear too because and it was crazy when that happened because right as that happened, I had a client that was going through this and it kind of spooked him, and I said, "Don't jump ship yet." The difference is you're doing it in a controlled medical environment with trained professionals. Matthew seemed to have an outlet to be taking this stuff home, and I don't think that's really appropriate. But so, are there any medical or psychological conditions that make ketamine unsafe or maybe not a best idea for someone?
yeah, I'll give you a perfect real life example. Matthew
Please.
Perry,
Mm-hmm.
all right, so he's dead. And I
Mm-hmm.
will add this, they threw in that there was also Suboxone in his system and so forth. I did a little
Oh,
video on him and I
yeah.
pointed out because I actually reviewed his entire autopsy. And not
Mm-hmm.
one place that when I looked at that autopsy, it was clear to me that it's funny because I do take care of a set of executive clients and Hollywood folks, and I
Right.
see this kind of thing often. You know, he wasn't being he had a diagnosis that wasn't even on there.
Mm-hmm.
Polypharmacy. He had a whole bunch of drugs on there, and a guy with a history of serious substance abuse was taking large loads of ketamine.
Right.
Ketamine was the primary contributor to his death. He got
Mm.
over sedated. I will stake my absolute entire career. I can't recall what I read right now, but as I saw,
Yeah.
oh, he's on Suboxone. Now, here for me, you're stigmatizing Suboxone. I assure you, he
Yes.
didn't pass out from the Suboxone. And there was other stuff. There was, if I recall, trazodone, Seroquel, which all can have sedating effects. But if you're saying people that shouldn't take it, I think people with a history of substance abuse should be cautious. And
Right.
then people with a history of severe bipolar with manic stuff and schizophrenia should be cautious.
Mm. Yeah. Tell me a little bit about that. Why specifically with schizophrenic and those kind of tendencies, if there's history in families, because I think sometimes people don't realize that could be waking a silent dragon to a certain degree. Is that correct?
That's what I'm thinking. Although
Yeah,
that's working with a different mechanism
for sure.
and dopamine. If I broaden the idea of psychosis, what that means, uh, 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 and, uh, and look at sensory changes, which dopamine doesn't do. But I'm sorry, not dopamine. Ketamine doesn't do. But that derealization that it has, depersonalization that it has, that out of body experience can have a profound effect on someone who may be or prone to suffering from delusions, false beliefs, and hallucinations,
Hmm.
right? Uh,
Yeah.
uh, and so why poke that giant?
Exactly, listeners. Exactly. But Dr. B, that's kind of brings up another kind of question. Now I'll get very vulnerable and open with you. I think by this time we have that kind of relationship, right? Yeah. So
Absolutely.
years ago during Coach Blue's hiatus, back in 1996 was the last time I ever abused any substances. But I remember one of the last things I ever used was LSD. And I had not a bad trip at all. In fact, it opened my eyes to a lot of things I hadn't really discovered. And I'll be quite frank and honest with you. I think it was the catalyst that put me on this awareness where I started to think outside of the possibilities that maybe all this stuff I've been going through was actually for my gain and not for my withdrawal. And that was the last time I ever did it. And I never had to do it again. But I'll always recall that clarity as something that was life changing for me. Now I know we're talking about ketamine here, but I want to shift gears just a little bit because there are now studies too about other forms of psychedelics, of psilocybin mushroom, things of that nature, through process of microdosing and whatnot, through medical attention. I hope that there's some studies going on with this. But when we think about these alternate forms of treatment, right, like the ketamine, like possibility of this, what is the biggest hurdle most people have to battle with? Is it the perception that because they are and have the ability to produce like abusing powers, like we could abuse these, that they're scary? Like, how do we approach this kind of stuff when we've been indoctrinated that on its own, out in the wild, it's potentially life or death, versus there could be particular benefits to doing this in controlled environments with a licensed professional clinician and things of that nature? Because I want to take away a little bit of the fear at the same time, make sure that we treat it with the respect that it deserves.
Yeah, and the way you brought up the LSD trip is something I really wanted to touch on. And I will get back to your question. But since
Please.
you brought that up, let me
Yeah.
bring that up. This is a great opportunity, and it's funny. It's a world where everyone's opinion counts. Ketamine, because people would, when I talked about ketamine or LSD, people would correct me, and they were wrong, and they would correct me in a rude way online.
I bet.
Ketamine is a dissociative anesthetic. Doesn't really have any hallucinatory effect. What you described, LSD, is a hallucinogen. At high doses, you can have disassociative effect. What's the
Right.
difference? Well, disassociation is disassociation. The primary effect of a hallucinogen is it alters perception, thought, mood by affecting how your brain processes sensory information coming in, and most interestingly for me, self referential thinking.
Right.
These are
I love
two
it.
different drugs. Okay, now, why did Ellis now? I absolutely believe a huge, tremendous therapeutic potential with hallucinogenics,
Hmm.
just with like ketamine, but now these are very different.
Right.
Uh, uh, Now, let me answer one little part of your question.
Yeah. Yeah.
Micro dosing is a completely different thing.
Right.
And it has to do with general mood every day, and it's very subtherapeutic. So we'll put that to the side, and
Okay.
we won't talk about that right now.
Right.
Going back to hallucinogens, now we can go back to our buddy Timothy Leary at Harvard,
Hmm.
60, 70 years ago, and he got fired from Harvard,
Mm.
and he was onto something. And then you have the counterculture movement, but that counterculture movement, you have to put it in perspective. It was an absolute threat to the government at a very volatile time, including the Vietnam War.
Right.
So this group was dropping acid. It was altering their perceptions of reality. Now, I'm not advocating anyone go out and drop acid. I think there's therapeutic potential
Yes.
in a therapeutic environment, and that at this time that means a very very controlled environment with therapy.
Right. Right.
So they banned it, fell out of favor. All research stopped. The first people that did research again was Hopkins in the
Hmm.
early 2000s. This stuff works for smoking cessation. Okay,
Wow.
it's
Yeah.
mind-boggling, and they just a few years ago got funded again to continue that. So the problem with it is the fact that it's work and so forth, and
Hmm.
there's an extreme amount of potential for end of life issues, for
Yeah.
anxiety, for PTSD.
Hmm.
Why is it amazing? And I'm going to give you one more piece
Please.
that
Please do.
in a and I might make a piece on this, and I
Yeah.
might
Yeah.
be the only one that's onto this.
Hmm.
What does this stuff do? If you think about the parts of the brain it hits and that self-referential avenue where it loosens, now you uh, put a kind of a metaphor, analogy, whatever you want to call it. You need to think about who you are and the problems you have in a Freudian context and think about it as the ego.
Yes.
Okay,
Yes.
the ego, now we can move over to get a sense of what that really means. Let's look at personality disorder theory. And when you go into like narcissism, personality disorder, about disorder theory, really for the most part says the crap is untreatable. This stuff is wired in rigid. Okay, I a little bit disagree because I believe there's a group on the East Coast that's making the headway. But
Hmm.
okay, let's accept that. Well, this stuff can loosen that perception of yourself in relationship to objects of the external world,
Yeah.
humans.
Yeah.
And during that opening, a therapeutic process can occur with professional badass therapists,
Yeah.
and you can treat a lot of these personality disorders.
Yeah. Yeah.
And there's some literature that's actually looked into this and positive results. And I'll give
Hmm.
you one more piece of this.
Please.
This could be a very, very valuable pharmaceutical technology to get a better understanding at the issues presenting us today, which tomorrow they're going to creep up and hit us in the head. Artificial intelligence.
Hmm.
What is the solution to the hard problems of consciousness, identity, intentionality, and what
Right.
it is to be a thinking, sentient being? This could be a vehicle to open for us so we can understand artificial intelligence better and artificial intelligence to feed us to understand what it is to be me better as an
Hmm.
intelligent being, and we could save disasters in the future in that way.
Yeah.
So that's my 2 cents
Man.
on uh, this
I
stuff.
love it. I love it though because I'm living proof, and granted, I did it under the umbrella of early 20s angst, but it did, Dr. B. In fact, it was literally right after I had had that experience that I walked away from everything else, and I can't be too hard on it when I'm like, for some reason, and for a long time, I didn't want to give it the credit that it deserved because I thought, how could a substance help me move away from substance abuse? But since 1996, there's been nothing because I felt literally as though I figured it out. The abuse, everything else that I experienced as a kid was almost kind of like in a Cliff Notes version, oh well, okay, so now what? And instead of going down the path of continuing hiding from and dealing with, hiding from dealing with the pain of the trauma, it was like this awareness. And I thought, there is such value there. And I would not be a proponent for more studies to be done on this, for more abilities and access for those that, again, have those PTSD type experiences, that stuff that really gets them stuck. I'm just curious, do you see that forecast change, or are we still going to be in a mindset of, the post, war era, Vietnam War era of it's all bad, it's a big fat no. Do you see the tides changing in this arena as well?
Not really. I mean, look, I don't want to be a
It's
pessimist.
heartbreaking. No, it's true. Yeah.
Uh, so I can't validate your experience enough, and I will caution people: Don't go out there dropping acid because
No,
you could have a very negative experience,
absolutely.
and it needs to be done right. It just happens by coincidence that you and thousands and millions of others have had a positive experience. I would even say, I used to have this little joke. If the entire planet dropped acid, there would be no wars.
Interesting. Yeah.
And I used to say that. And so, do I see stigmas changing? I don't. I see
Yeah.
everything is financially driven. And
Right.
once you, I mean, look at the before the 1920s, nobody thought of opiate addicts as evil, scary, the scum of society. No, you had an addiction, you went to the doctor, he managed it for you, you raised your family, lived well, etc., etc., etc. Here we are, a century later, and supposedly in the last 20 years, we've been in this MAT, harm reduction,
Yeah.
educating everyone's kids has been affected. It's not much better. It's tolerated. So why would I think a society would all of a sudden wake up and
Exactly.
say, you know what, this can have a potential to move us to a higher level of civilization and avoid conflict, wars, diminishing resources, destructive destroying of the planet? I
Mm-hmm.
don't see that, but I
Yeah.
think it can.
Yeah. See, and that's the great dilemma. See, so moving back through these alternate ways of, I think, overcoming some of these mental health and addiction type barriers. I'm curious, even specifically with ketamine, like you'd said, after having some failures in medication and whatnot, then that might be a window to open up to go explore that. Post ketamine treatment, is it wise to maintain maybe or even prescribe like the same medication or something different? Because I'm curious about like if for some reason your brain's not adapting to produce whatever chemical you're lacking there, and we do the ketamine treatment, it's not a silver bullet. It's a process to get you through that really heavy time where you might be questioning, self harm or whatnot. Even post that, you've still got to maintain a certain level of therapeutic involvement, medical assistance, right? I mean, I don't think people walk out of an office after having received a ketamine treatment and being like, well, one and done. Like, there's still a lot of continuation, I would imagine, even post treatment. Wouldn't Is that correct?
I don't know how to emphasize that
Mm-hmm.
truth enough. Okay. Now, this is something hopefully you have a competent psychiatrist that
Yeah.
can reinforce this idea. And it might be you have to go back on your baseline antidepressants, continue whatever else is going. And, you talk, the thing is, when you're damaged, and most of us are, it's a lifetime process. It's not a place you're trying to get to. You keep
Right.
doing this till the day you expire from this planet. Growth never stops. When you're in a pathological state, it absolutely never stops. If people want fast, quick, wham bam, thank you, ma'am, treatments, they shouldn't. You're going to fail. You're going to hit a wall. So you are 1000% right. And I would say that, well, what is it? It's tailored and individualized. If you were seeing a great therapist, and if your baseline was, I don't know, well, Butrin, that's for the your medication profile and the
Mm-hmm.
psychiatrist decide. You guys might decide you need to stay on that baseline on this particular event. Things went haywire. Continue your therapy. Continue to do everything else.
Yeah. Yeah. See, that's the guy,
100%.
listeners. Yeah, that's the bonus, listeners, is that it's not if everyone tells you this, if you think it's a one and done, you're mistaken. There's still work that needs to be done. The hard parts in the middle are simply that they're in the middle, right? There's still a lot of life to live. There's still a lot of experience to be had, and I think that's something that we've got to wrap our heads around. Is there is no golden thread that's going to sew up all that stuff. It's going to be a lifelong, ongoing process. But I'm also curious about this too, Dr. B. I mean, Matthew Perry did have, I think, correct me if I'm wrong, he did have access to it, at home. This is typically something that's done in a facility or a program. Do they send people home with a ketamine type medication, or is
Yeah.
I don't know.
Yeah. So let's really make sure the listeners get this point. Unless you are going to medical doctor, psychiatrist, and he goes through the checklist of why you should get ketamine. Everything else is, possible, and that's
Right.
not treatment of ketamine. So he was getting pills, I think, and he had it home. Okay, and he had money and he had resources, and that's what I actually see with a lot of stars is, their medical providers and the people around them actually
Hmm.
exacerbate their fantastic delusional detached sense of who they are and don't
Right.
really do anything positive for them. I mean, there's so much money involved. You got to be able to say, if you want to get better, I can get you better. You don't like it, fine. I'm not going to disrespect who you are as a human being, and that goes for you or the patient paying less, or so forth and so forth, for everybody. But I'm not going to feed into and validate your desires because they're pathological, your
Right.
sense of yourself because it's pathological, and your grandiose sense of entitlement for cash because
Yes.
that's what landed you here in the first place. And
Yep.
so yes, it's possible for him to have pills at home, but remember, nothing except the S enantiomer nasal spray in a psychiatrist's office is approved by the FDA, and anything is possible.
Yeah. See, that's listeners, you guys, this is why I love having Dr. B on the podcast, is because it's that kind of insight that I think answers some of what we call the layman's questions about, like, how does all this stuff work, Dr. B? I love your interest in this by saying that, hey, it's not a one size fits all. There's a lot of different things, like you even talked about Matthew Perry, even using Suboxone, and finally, after so many years, is that becoming more of a mainstay thing to help people without the stigma that's attached to it. We got to have open minds with this, but we also have to have minds that are being willing to see all sides of this: the good, the bad, maybe some of the ugly, and then the benefits. I really do appreciate that about you, Dr. B, is that you advocate for this kind of stuff with the folks that don't know, that have had a lot of other problems in life, trying to explain what they're going through. I know that you do things very different with your patients and the folks that you work with, because you take the time. And I think that's one of the biggest things we need to do is we don't just write the prescription and throw it at them. Whether it's talk therapy or medical like intervention, you've got to get to know the person. And then with a team, listeners, that you develop with your doctor, with your psychiatrist, with your therapist, with your family, you come up with the best plan. These multidimensional kind of treatment teams, Dr. B, they are so vitally important. And in communication, I would imagine, I've had clients that have gone and gotten treatment for this stuff using ketamine, and have come back and showed me a therapeutic like handout that they've read and kind of responded to with not a lot of process. And so we'll do it in therapy. But I'm thinking it's important for us to have a fully loaded team if we're going to experience something like this. Um, I think that that's kind of the keys to success, wouldn't you think? I mean, it's not just a one size fits all with one person dictating all of it.
Yeah, you've absolutely hit the nail on the head. But I will also say, on the side of the practitioners nowadays, that's really not possible, sadly, for the average patient.
Right.
Because if you're talking about insurance payments, they're pennies on the dollar.
Yeah.
So, so though, again, this is my dark side, but I believe I'm telling the truth.
Yep.
These things don't exist in our society anymore. So, and I want to give listeners something practical to go on, right?
Mm-hmm.
Uh, and for that, I'm going to use an example, and I hope it benefits everybody out there. A lot of people might be listening out there, and a good chunk of them will completely misinterpret what I said. The
Yeah.
only thing they're going to get out of this is, this guy's an idiot. I went and it worked for me.
Yeah.
They forgot that I never said it doesn't work. They didn't
Exactly.
listen to the fact that I said it's great therapeutic potential. And there's one piece of this that in our society we don't really respect anymore. Your individual experience is relatively on the totem pole of making decisions for society meaningless.
Yeah. Yeah.
Okay? If you come and
Mhm.
tell me, man, you're an idiot because I use heroin 1 day a month for a couple of hours, and you are an absolute moron because it's all this, it's nonsense. That's your
Yours.
individual experience. My job is to get, for as faulty and broken the system is, the institutions are, the clinical literature is. I spent a lifetime trying to immerse every broken piece and every piece that works. And I want to leave people with that
Yes.
is please don't misinterpret and understand that you are also limited because you need an outside perspective and a professional. And in terms of what you said, you need teams. They don't exist anymore because it doesn't
Exactly.
pay. And so
Yep.
find yourself a provider that at the very least understands all of this stuff and attempts to provide care with the spirit of these issues. I might not get to spend 2 hours with you because I can't afford to spend 2 hours with you. But I'll
Precisely.
tell you what, in the next 10 sessions, I know I will get to build a rapport with you in these 10-minute sessions and understand what I need to understand, and your care will even improve.
Beautiful.
That's one of the messages I want to put out there is I don't want to be delusional about a broken system and
Hmm.
broken perspectives.
I love it. Beautiful, Dr. B. That's why you are always on our mind when we talk about these kind of difficult subjects. So I appreciate you making yourself available. You have no idea how much we truly appreciate your knowledge, your time. One more time, tell these listeners how to find you and follow you, because listeners, I'm telling you, you're going to want to jump on all these socials and follow Dr. B. He provides excellent content minutes at a time. How do they find you?
You're too, you're too kind. So on YouTube, all around, we were at Dr. B Addiction Recovery. Where I just started the channel back up again with shorts. Longs are going to be coming. I have a lot of explosive stuff on MAT. Why? Actually, I'm
Beautiful.
the MAT
Yes.
guy, but I'm going to talk about why it doesn't work. Uh,
Hmm.
but it's a Dr. B 360, and part of the reason is, I the reason it's 360 is because I have a lot of interests besides
Hmm.
substance abuse.
Yeah.
And I consider anything that is of importance to society, humans, their growth, development, and our survival. So that's why we changed the name. But it's Dr. B
I love it.
360. We're on TikTok, Facebook, and
Good old
Instagram.
Instagram. Hmm.
And my favorite is YouTube, the shorts we do. But I want to
Yes.
get back into my longs.
I love it. I love it. So, listeners, you've been well fed. We'll put all Dr. B's socials on there so you guys can follow, watch, and support. Dr. B, again, this won't be the last time we talk to each other. I know that for sure. But listeners, you've been well fed. Please keep this in mind. If you have anyone that might be struggling or needing a little bit of support, specifically if they're looking for MAT resources, we will also link the other podcasts that Dr. B has been a part of, because there's some great content on that very subject. Thank you all so much for all that you do for Team Addict to Athlete. Until next time, do your best to turn your mess into your message.